Hello, I'm Dr. Keith Crawford. I'm the Director of Patient Education, Clinical Trials at Prostate Health Education Network. And this is another one of our learning sessions. And this is sponsored by Merck. I want to welcome everyone, and I really want to thank you for joining our educational sessions on clinical trial opportunities for people with metastatic castration-resistant prostate cancer. Um, Today, we're going to have Dr. McKay, and she will help us understand what metastatic castration-resistant prostate cancer means, the clinical trial participation, what it may involve, and what patients and caregivers may want to ask their care team about these ideate prostate studies. Um, Remember, this session is educational, general education only. And it's not for personal medical advice. It doesn't replace a conversation with your own doctor or your study team. And please don't share any personal health information in the public Q&A session. What I want to do before we bring on Dr. McKay is I always like to tell you what I'm going to tell you. Then we're going to tell you, and we're going to tell you again. So I'd like to share. And yes, this is our learning session, and it's going to focus on clinical trials for men with metastatic castration-resistant disease. Now, some things that I wanted to go over is the overall topic is about antibody drug conjugates. It's kind of a guided cancer drug, and it's going to be focusing on an antigen on the surface of cell. It's called B7H3 target protein. It's a protein. Now, an antibody drug conjugate, ADC, has an antibody, and that's a molecule that is normally produced by the body, but it can be a drug that specifically binds. It's like binds to this particular protein, B7H3. Now, it has a linker, and it's linked to a payload or our drug. So an ADT has, again, three parts: the antibody, it finds the target on the cancer cell. The linker holds the drug until it reaches the cell. And the payload, it's a compound or a chemical that kills the cells. So what's important and the goal here is to send more drug to the tumor cells while reducing the exposure, the amount that the rest of your body is exposed to. So also, I want to let you know, these are some helpful words that you need to know during this session. Obviously, metastatic castration-resistant prostate cancer, MCRPC, and this is prostate cancer that is spread and keeps growing even though testosterone is very low. Clinical trials is a research study that tests if a treatment is safe and may help people. Investigational drug is a study medicine that is being tested and is not yet approved for this use. Randomization is more of a computer assigns participants to a treatment group, so results can be compared fairly. Tumor tissue samples, tissue from a biopsy or surgery that may be used for required trial tests. Now, if we look at the ADC side, safety and mechanism, you'll hear about antibody drug conjugate. We spoke about that. We talk about B7H3. That's a marker found on some cancer cells. And this is what the antibody portion binds, hunts down and targets. An antibody is a protein that can recognize and attach to a specific cancer cell, specific marker on a cell. And the linker and the payload is what the antibody is linked to, and the payload could be radioactivity, or it could be chemotherapy. And then there's ILD or pneumonitis, lung inflammation, and report new cough, fever, or breathing changes right away. We just want to make sure everybody knows that. The patient takeaway: it is okay to pause the conversation and ask, What does the term mean? We want to make sure you understand that. Now, I'll stop sharing. Okay. And I'm going to bring on Dr. McKay. Dr. McKay, thank you again.
Of
It's
course.
great to see you.
It's my pleasure. Thank you for having me.
And so I'm going to share slides for you, but I just the our goal is to make the information more practical and understandable um, when we start talking about clinical trials. And the kind of at a high level, I want people from your own words. What is metastatic castration-resistant prostate cancer? And how would you explain that to a doctor? I mean, to a patient and to a doctor.
Mhm. So, metastatic castration-resistant prostate cancer is prostate cancer that has managed to grow despite having very low levels of testosterone. And so, even though somebody may be on hormonal therapy to bring down their T levels to very low levels, or they have had surgery so that they're not making any testosterone, it's having the cancer grow despite that.
Okay. So now the patients who have metastatic castration-resistant disease are the ones that can take advantage of this clinical trial. So
Correct.
I do have some slides for you, and I'm going to
Yes.
share those.
Yes.
Okay.
And I think as you're pulling this up and we're talking about antibody drug conjugates, because I know this is a mouthful, the word
Hmm.
antibody, many people may not even know what exactly that is. And so when I think about an antibody drug conjugate,
Hmm.
you can think of it like a Trojan horse.
Okay. Okay. That's
So I'm gonna take you back here.
it's
Go to Sparta with me, okay? Go to
I,
Sparta with me, Dr. Crawford, okay?
I took mythology in high school.
Okay. So you can think of it like a Trojan horse.
Okay.
There is a marker on the tumor that is going to guide a targeted therapy into the tumor cell.
Okay.
So we're bringing in the Trojan horse is like coming in, binding onto the surface of the cancer cell. And then the cancer cell opens up the door when it binds to the surface and
Hmm.
brings in whatever it is that's targeted there, i.e., the horse full of soldiers, which is basically you target B7H3, which is what's on the cell surface, and then you internalize when the compound binds, you internalize it into the cell, you bring it inside the gates of Troy,
Right.
and then inside the gates of Troy, you unleash the soldiers. And that
Ah,
is the drug. The drug is the chemo. It's a targeted chemo that goes inside through the door. The way that it enters the door is through B7H3 because B7H3 is on the tumor cell.
right.
Then you internalize the poison and
Mhm.
it causes the cancer cell to die.
Mm. So,
And so it's
go
kind of
ahead.
like very targeted chemotherapy. It's
Right.
targeted chemo that leverages kind of like it's almost like a not to say a decoy, but it's leveraging something that's on the cell surface to bring the chemo directly into the cell.
Okay. So it's nice that you said it that way because when we think about chemo, right? Chemo has a tendency to affect, if you just take it in your blood, it has a tendency to affect all the cells in your body.
Correct. It's not specific. It's
Mm.
not specific. You know, the chemotherapies there, they disrupt certain processes of a cell, but it's not specific to a cancer cell. There's nothing specific
Right.
about docetaxel chemotherapy like that is specific to the prostate cancer cell. So this is sort of the new way of how do we better personalize therapy and how do we develop better precision medicine tools that are specifically targeting the tumor. And this whole concept of an antibody drug conjugate or something where the concept of targeting something on the cell surface of a cancer cell, linking it to something that's going to kill the cancer cell, it's it
Yeah.
goes beyond chemo. It's how do I target a protein that's specifically on the tumor and I link it to something that's going to kill the cell. So
Hmm.
ADCs link it to a chemo that's going to kill the cell.
Right.
Radioligands link it to a small radioisotope, an alpha particle, a beta
Right.
particle.
Right.
T cell engagers link it to your immune system. Bring in the T cell, fight the tumor. So, this whole concept of something is on the cell surface that's specific to the cancer cell. I'm going
Hmm.
to target it with a drug attached to something that's going to kill that cancer cell.
Okay. All right.
So, just to step back, and I like the Trojan horse analogy for ADC.
I like it too because you don't have a lot of collateral damage when you go into the compound and fight.
No, the tumor's like, hey, come on, you're knocking on my door. Come on in. Come right on in.
Okay, so I like that. I
And
like
then the army is released inside the tumor cell, you know?
so now so now we have a good understanding of one 80 what what metastatic castration resistant prostate cancer is, and that's the can people who are candidate.
Hmm.
And then 80 the drug is ADC.
Hmm.
Okay. Antibody that links to the treatment option.
Correct. Yeah, it's antibody. So the antibody targets something on the cell.
Right, right,
Drug is what is my killing device.
right.
Conjugate is I'm linked.
Okay,
Antibody, drug, linked.
great. And that's it.
Yeah.
Those are the three components of
Correct.
drug conjugate. So now everybody should be able to answer that question. So now, Jerry, do you have the slides available?
Fantastic. So thank you all. I really am grateful to be able to highlight this and talk to you all about the ID8 trial. So we can go to the next slide, which I believe is my disclosures, and just a little bit of way of background for me. I'm a medical oncologist at the University of California, San Diego, wear multiple hats here, run our clinical research program, and lead our genitourinary oncology group, and have done a lot in the prostate cancer space. So we can go to the next slide. And so we started to begin to talk about what is MCRPC. And first, I'll also say there's a movement to move away from the term castration resistant. Nobody likes the word castration, and there will be
Oh,
some new terminology that'll be developing called APMS and APMR instead of CRPC and HSPC, but that's for a different day. But in essence, this is what we talked about. This is people who have prostate cancer that has metastasized outside of the pelvis to other parts of the body, whether it be lymph nodes or bone or liver or lung, what have you. They're on hormonal therapy to drop their testosterone levels down. But despite the fact that their T levels are very low, the cancer has figured out a way to grow. And that's either manifested as a rise in PSA or new spots developing on a scan, some evidence that the cancer is growing despite low T.
right.
So we can go to the next slide
Oh,
and
but you know what
feel free to interject. Yeah, absolutely.
I was going to tell you something. So we're slowly introducing antigen pathway modulation
Hmm.
or antigen pathway.
Androgen pathway modulation sensitive. So
Okay.
APMS for the old school hormone sensitive disease.
Right.
And then the old school CRPC will be androgen pathway modulation resistant.
Distance. So we wanted, drop these little pearls earlier on. So the audience has heard it here for the
Yes.
first. I just want to let
Yes.
you
You
know.
may start to see this. And I will say there was a recent new drug approval last week that took place, and that drug they're starting to use that terminology in the new drug approval, the APMS, APMR. So you all, this is not the purpose of this specific discussion, but you may see some evolution in the terminology. Okay.
Yes. And so that's what
And
I like. I just want to make sure that everybody understands that it's going to be sooner. It's sooner. So I didn't even know it
yes,
had taken place, but I'll let
yeah,
you proceed. Okay. Thank
yes.
you. Thank you very much.
So, one of the biggest things whenever somebody transitions to MCRPC is really the kinetics of how we monitor an individual may change, um, and the different treatments that are available to any one given individual may change. Generally, the backbone of treatment for somebody that is progressing after being on intensified hormone therapy, there can be a switch to a different kind of hormonal agent, though there's a lot of data to suggest there's cross resistance and that strategy doesn't work very well. There could be some radiation approaches, just targeted, radiating spots that are causing problems. Focal radiation therapy is more of a symptom improvement as opposed to a life prolonging maneuver.
Hmm.
There's immunotherapies that can be used in select populations. You know, um, the backbone of treatment, honestly, for people who have progressive, metastatic resistant prostate cancer is chemotherapy. With a taxane chemotherapy, whether it be docetaxel or cabazitaxel, that is the backbone of treatment. Um, Targeted therapies for a select group of individuals can also be considered. Um, whether it be a PARP inhibitor if somebody has a specific mutation. Somebody may elect to not undergo any treatment, depending on what's going on with them. And of course, clinical trials are an option. So there's a lot of different things that can be considered at this juncture. I think chemotherapy has been a tried and true therapy that's been around since 2004, actually. And there's not been a lot of, it's definitely a life prolonging option for individuals. Okay.
Hmm.
So
Okay.
the next slide is, well, okay, I mentioned on that list clinical trial. What is
Okay.
a clinical trial? A clinical trial is a experiment, actually. We're looking to answer a question around whether a specific hypothesis that somebody may have is is true or not true. There's a lot of different kinds of clinical trials. Clinical trials come in all different shapes and sizes. And you could have a clinical trial with a survey intervention. You could have a clinical trial with an exercise intervention.
Right.
You can have a clinical trial with a diagnostic. Many of the clinical trials that you all may be thinking of include a trial of a therapeutic,
Okay.
something that we're giving to somebody to test whether it's safer, works better, what have you. There's all different kinds of clinical trials. So you can, like I said, have a supportive care trial, a diagnostic trial, a therapeutic trial, but there's also different phases of trials. So there's phase one, phase two, phase three, there's even phase four studies. Phase one generally are looking at what is the right dose, is it safe? Um, they generally are what we call open label, meaning you know what you get, I know what you get, everybody knows what they get. They tend to not be randomized. Um, and generally, most people get drug. Phase two is looking at some dose optimization and a signal of efficacy.
Hmm.
What's the benchmark with this agent? And phase three is testing, okay, what is the benchmark of what the standard of care is? And does this trial, improve upon that? Or, it's testing, it's usually phase threes are usually randomized and they're testing against a standard. Now,
Hmm.
with regards to placebo, sometimes this comes up of, you know, not every trial is a placebo-controlled trial, and the only time you utilize a placebo is, when you're trying to isolate a specific drug. It's usually compared against standard of care. So if the standard of care is one drug and you're looking at two drugs, everybody gets the standard of care, but then half the people will get the one drug, half the people may get the placebo. Not every study is a placebo-controlled trial, nor does it have to be. And generally, when placebo-controlled trials are done, everybody gets the standard of care, whatever that standard of care happens to be in that setting. In some scenarios, that standard of care is observation. In some scenarios, that standard of care is chemo or an oral pill or what have you. Um,
So just to be clear, that just so everyone understands, standard of care,
mhm.
that the majority of times, no, all the time you participate in a clinical trial, you will get the standard of care at a minimum.
Correct.
Okay, just want to make sure.
That is correct. If when we're talking about sort of like, phase three trials, okay. And I'll bring us back, like our I could spend hours talking about clinical trials. Like the first official clinical trial was actually um assessing uh you know uh, sailors that were on the ships, kind of going back and forth between Europe and the Americas, and many of the sailors were
Vitamin
dying on the
C?
ships.
What's
That this
this
is the
vitamin C?
vitamins. Yes, this is
Yes,
scurvy.
yes,
They were all having
yes.
scurvy on the
Sure.
ships, and
Yep.
they were like, what's going on with my sailors?" And so one of the people on the ships kind of developed these different concoctions for and having the sailors, drink some vinegar or take some tonic water and take a citrus juice and, wine. And, we all know the story that, the sailors who drank the vitamin C water or the citrus water were the ones that had improvement of their symptoms. So that's like the first official, like, clinical trial. But anyway, I digress. I'm taking us back to all
No,
the
no,
folklore
no,
stuff. You
no.
don't need
I
this,
mean, with a
you
lot of
know. But
people,
anyway, let's get through the next slide.
I think people appreciate that because you
Yeah.
bring it down to simple. Now they understand just the basics because everybody's kind of heard that in grade school.
Yeah.
That,
And it's
yeah,
important. Like we need trials. We need trials because they help set the new standard. And I think when I like to think about trials, like you're always in control when you're
right.
on a trial, actually, you as the patient.
Hmm.
And when I look at clinical trials for my patients, there's only a short list of things that I could prescribe for any individual who has advanced prostate cancer that's hormone resistant.
So the
That
take
list, the list is not long.
right,
And so clinical trials offers an opportunity for me to like expand the armamentarium of
right,
bullets that I have in my back pocket for treating their cancer. That's how I think about trials, you know?
and w- so one thing we want everybody to understand. Yes, this is research, but it's carefully controlled. So
Yes.
these two clinical trials you're going to discuss are carefully controlled research studies.
Correct. And there's a lot of oversight. There's, ethics committee, advisory committees, the FDA, many groups that give oversight over how these trials are designed and conducted to make sure that everything is happening in a right and just way. But we can go to the next slide.
Hmm.
And so now here's our opportunity to learn about two clinical trials for metastatic castration-resistant prostate cancer. Okay, we'll go to the next slide. And the first one we're going to highlight is the ID8 Prostate 01 study, which is a phase 3 trial that's looking at IDXD versus docetaxel. And so phase 3 means this drug has already proven that it's safe. We've already figured out the dose. We've already demonstrated that there's a strong signal of efficacy. And now we're testing it in the phase 3 setting to see, is it better than what we already do?
Hmm.
And
So,
so,
a quick question.
mhm,
IDXD, is that the drug? Is DXD the drug?
correct. So it's right there kind of on the bottom. Ifintamab deruxtecan. Okay. So that is the drug, the
Okay.
investigational drug. Okay. But I think a lot of us, for simplicity's sake, just call it IDXD. Now,
Okay.
this is the Trojan horse that I was talking about. This is the antibody drug conjugate. It's
Hmm.
a targeted immunotherapy. And for people who are already progressing on intensified hormone therapy, um, chemotherapy is a standard of care and is a life prolonging option for many individuals. So this is looking at, okay, compared to chemotherapy, is this better? Is this more effective at improving outcomes for patients? And so we've all on this trial, we can go to the next slide. Um, well, this is the other side. So everybody gets treatment in the context of this trial, the phase 3. You either get chemo or you either get IDXD. The
Okay.
other trial that we're going to tell you about is ID8 Prostate O2. So this is a phase 1-2 study that's a little bit different because it's looking at many different combinations of IDXD.
Hmm.
Also looking at monotherapy, but looking at combinations. So on this trial, we are looking at if we combine IDXD with other drugs, combine it with oral hormonal therapy or other sorts of agents, is it safe? What's the right dose of the combinations? And is there a signal that it's more effective? So
Okay.
this is a little bit of a different study. The first one is a very large registrational phase 3 study. If that trial is a positive trial, the hope is that this will result in a new drug entering in the armamentarium for people with prostate cancer. And so, and that's just looking at monotherapy by itself, IDXD given alone, and you're comparing
Yes.
to chemo.
So
This
just
trial is
mhm.
looking at it in combination to see if we actually combine it with another agent, does it work even better? So they're two different kind of trials.
Oh, I see. I see. And so I wanted to back up a little bit.
Yeah, we go back one slide.
Okay. Now, the first thing I want to bring is that the slide back up a bit, Jerry.
Yeah, go back one slide.
One slide. This is a phase 3.
Correct.
Okay. And then the second trial, ID8 prostate O2.
Oh, two.
Go to that, Jerry. The next slide. This is a phase 1/2. What does that 1/2 mean?
So the 1/2 means it's looking at what's the right dose, that's the phase 1,
Right?
and is there a signal of efficacy, is the phase 2. So if the phase 3 that we talked about, I don't want to confuse things, I want to try to keep them separate. The
Right?
phase 3, we've already done studies with IDXD monotherapy by itself.
Right.
We've identified the right dose when it's given by itself. We identified the safety profile when it's given by itself. We've identified the signal to benchmark of how we think it's going to work.
Right.
And we've gotten to the point of, okay, we believe that this is going to be better than chemotherapy. So we're going
Okay.
to run the experiment with IDXD given by itself to prove, this is what the test is, to prove that it's better than chemo.
Right.
So the phase 3 is looking at, okay, let me just test this drug alone against chemo. It's an open label study. There's no placebo. Everybody gets treatment. You either get IDXD or you get chemo. Because if you didn't do the trial, chemo's on the table as to what you would do to treat the prostate cancer.
I got
So
you.
that's the standard of care. Okay.
Okay.
So this trial is saying, okay, well, we know about the monotherapy. We know how the monotherapy performs and what's the right dosing and that. But can we enhance the activity of this drug? If we combine this drug with another effective prostate cancer drug, can we have a synergistic effect?
So
So
it's like
this
a one-two
study,
punch. This is like a
it's like a
one.
1-2 punch. So this study is a little bit, earlier on because it's actually looking, okay, if we do that, how do we do it in a safe way? If we
Mhm.
do that, what's the dose of the IDXD? What's the dose of the other drug? Can we combine these two things together to in a right fashion to see if it works even better? So the phase 1 piece of the phase 1-2 is how do I understand the right dosing? The phase 2 piece of the phase 1-2 is, okay, what's the signal that it's going to work better? And so this is like a smaller study. It's what we call kind of like a basket study where there's or umbrella study, where there's going to be a bunch of different groups that get enrolled looking at, okay, this combination, that combination, this combination, that combination, and let's try to figure out what's the right dosing for each one of these combinations, and do each one of these combinations do better than the monotherapy. So that's why on this trial, there's also a monotherapy group because we're kind of level setting. Okay, when I give one drug alone, how is that one drug going to do? But when I give it in these different combos, are those different combos going to be better than just that one drug alone?
Mhm. You know
So,
what?
yeah.
Could you? I'm sorry,
Mhm.
Jerry. Could you go to slide 11? I think it'll help our audience understand exactly what Dr. McKay is talking about. Is that good?
So this, yes. So this is um, going to the phase 3. This is prostate 01, ID8
Right.
01.
Right.
And again, these are the two groups.
Okay.
So the one group is going to get chemo,
Mm-hmm.
one group is going to get IDXD. It's open label. Open label means your doctor knows and the patient knows what you're getting. Not blinded, so everybody's aware what they're getting. No one's, hiding the cards here. Like you,
Right.
you
Right.
will know if you're going to get chemo, you're going to know if you get IDX.
Right.
There's no placebo. Everybody gets something. You either get chemo or you get IDX, but it is randomized, meaning I don't get to pick what you get and you don't get to pick what you get. It's a
See.
flip of a coin. And
Okay.
you
So
have
that's
a
that computer generated.
correct.
Yes.
You
Okay.
have an equal chance of getting in group one or getting in group two.
So
Nobody
it's
can
fair.
say
So
it's
it's
fair.
fair. It's fair.
Right.
Okay.
Right.
Yes.
So that's O1. And if you want to go to the next slide, is I think is the O2 slide.
Yes.
So the O2 slide, again, different kind of study.
Right. Right.
This is a study looking at different combinations together. There's going to be one group that just gets the drug by itself. It gets IDX by itself, IDXD by itself. But then we're looking at combining it with other types of prostate cancer therapies. This is the 1-2 punch. So,
Mm,
like group one, we're actually going to combine it with chemotherapy. If we give chemo with the targeted chemo, what's the safety profile? Can we do it? Does it work better?
mm,
Okay, if we give it with another drug called opevestat, which is a type of next generation hormonal agent, it's an oral drug. Does
mm,
that work better than group two? Group four is giving it with your standard, next generation hormonal therapies, the enzalutamide, abiraterone, you're probably familiar with. So
right.
this trial is looking at giving IDXD in combination with another agent that has activity in prostate cancer to see it's better than just giving it with IDXD. So
Mm,
on this trial, there also is no placebo. It's not blinded. You know what you get. I know what you get as your doctor.
right.
But there is a randomization component because you could see there's a bunch of different groups. So you
Right.
don't get
Right.
to pick what group you're in.
Right.
And there's going to be an allocation of people to any one of the groups. But the difference here is nearly all the groups will be getting IDXD. And I think I misspoke. Group one is not the combo of IDXD with chemo. It is just chemo. Okay.
Okay. Okay.
So I misspoke there. So groups 2, 3, and 4 all include some IDX component, whether it's given by itself or with another drug.
Can I add a quick question?
Mhm.
Do you know? Okay, because IDX is different than a taxane, right? Do
Correct.
do you know how once it's inside the cell, once that Trojan horse is inside the gates and the troops come out, how do the troops kill the cell? What
Yeah. So very, very good question. And I think when we think about the
hmm
way that this drug works, it's linked to a chemotherapy. And
right.
the chemotherapy that it's linked to is DXD.
Oh,
DXD is the chemo. And it's what we call a topoisomerase 1 inhibitor. I know that's a mouthful. Okay.
I'll stick with DXD. Okay.
DXD is the chemo component,
Correct.
deruxtecan. There's actually a lot of other drugs that utilize DXD. There's
Hmm.
TDXD in breast cancer, trastuzumab,
Hmm.
deruxtecan. There's a lot, and so that DXD basically gets in the way of how that cancer cell unwinds and copies its DNA. And by
Ah,
inhibiting that process, it kills the cancer cells.
okay. So that's why there's that 1-2 punch. So you can break up the DNA or somehow interferes with the DNA repair, and then
Mhm.
you hit it with another with the taxane, or you decrease the steroids in three.
Yeah, so I misspoke. You're not combining it with a taxane for group one. I misspoke
Oh,
there.
oh, I'm sorry,
Group
sorry, sorry.
group group two, group three is you're combining it with an oral hormonal agent.
Ah,
So
okay.
Opeve is a drug that's it's like a we call it a CYP11 inhibitor.
Hmm.
It blocks testosterone production in the adrenal gland at even a higher level of what abiraterone does. So it's an
Hmm.
oral hormonal. So we're going to say, okay, we're going to give you the IDXD that's linked to chemo. The chemo gets in the cell, messes up the DNA of the cell dies. We're also going to give you another oral hormonal agent
Right, right,
and
right.
see if the two are going to work better together. Group four is taking more traditional oral hormonal agents, abiraterone and enzalutamide, and pairing it with IDXD.
So,
Okay.
so can I ask you a question?
Mhm.
In let's say group four. So if you're a metastatic castration-resistant prostate cancer patient, what happens if you do you have to have, well, you couldn't participate in group four, could you? Or
You
do you,
could participate in group four. Group, so there's a lot of different kinds of therapies that people can get when they're or before they become resistant.
right, right.
So, say for example, somebody was getting ADT and abiraterone,
Okay.
and then they progressed on it. They could conceivably go into group four, but they would not get abiraterone, they'd get enzalutamide.
Okay, I see what you're saying. So you don't
So,
have to fail on all of the
no,
next
no,
generations.
correct. No, no. Yeah,
Okay, okay.
exactly. Yeah,
Okay. So you could just fail on one, and then you in that you're resistant, and as long as you're resistant to one, you could conceivably participate
correct.
in O2. Okay.
Correct. Correct. So I don't know if we want to, I know we kind of jumped ahead to get to the schemas because I think the schemas are really, they give a better picture. But if we want to go back, I want to make sure I just didn't miss any content.
So if
Let's,
we go back to nine, Jerry, I think that was a
yeah. So, I think we covered this. We talked about the monoclonal, the drug and the linker, the Trojan horse.
mhm.
I think we're good with that. We can go to the next slide just to make sure okay, and we've talked a little bit about this. IDXD is the name of the drug. The
Right.
DXD portion is the what we say is the chemo portion,
Hmm.
and the antibody targets a specific protein on the cancer cell. And then
Hmm.
when the antibody binds that specific protein, the doors open,
Right.
the agent comes into the cell, and then the DXD kind of messes up the DNA within the cell, and the cell dies. Okay,
Okay.
so we talked about that. Okay, let's go to the next slide. And then this is O1. We talked about this. We can go to the next slide. And this is O2. I think we talked about this. Okay. And then this is sort of the different ways that the drugs are given. I'm not going to go through this. The chemotherapy is given IV every 3 weeks. It's given with prednisone. It's very standard. The IDXD is given IV every 3 weeks. That's the standard administration. Opevastat is given orally with steroid replacement, and then abiraterone and enzalutamide are oral, and the Abby is given with prednisone. We can go to the next slide.
Okay.
And then I do want to call this out,
Okay.
interstitial lung disease.
Right.
Okay. So with many cancer therapies, each drug has its sort of side effects
Hmm.
that can come on with that agent. And there are side effects of special interest. There are things that we look at that are rare events, but they're significant events. So
Hmm.
we have a very, you know, like high index of suspicion. We have a very keen eye on looking for these events. They're not very common, but we definitely don't want to miss them. So interstitial lung disease or pneumonitis is sort of an
Right.
inflammation of the lungs or scarring that can happen in the lungs. And this is a side effect of IDXD, and it in actuality can be a side effect of just the class of antibody drug conjugates. So this
Right.
is not necessarily unique specifically to IDXD, but it can come on with IDXD. And we do a lot of education for
Hmm.
patients and investigators and clinicians alike about being on the lookout for this. It's rare, it's not common, but when it happens, you want to catch it early and treat it to prevent people from having any issues related to it. So we
Okay.
have a lot of education around this. And so, what are the symptoms of ILD? They could be fever, they can be shortness of breath, a cough, any of the above. And it's important when we consider patients for receiving IDXD, you know, if somebody has underlying lung disease, maybe they've got COPD, maybe they already have underlying fibrosis, maybe they already have some emphysema, they're probably not a great candidate for IDXD because we don't want to put anybody in a situation where things can
Right.
be exacerbated.
Okay.
Now, many people don't have such things, but again, we have to make sure that
Right.
we are mindful of this. So it's always important to ask doctors or have doctors make sure that they're asking about symptoms. You, as patients, need to make sure to share those symptoms. On this study, patients get scanned very regularly every 6 weeks. So we're constantly looking at the lungs. In addition to looking at the cancer, we're also looking at the lungs, making sure there's no signs of inflammation. If we do see it and we catch it early, it can
Hmm.
usually be self-resolved with steroids, medications, oxygen therapy. You know, I don't want to, scare people, but like, you know, very, very, very rarely, if somebody has a very refractory case of ILD, it can result in the lungs just not working. They're just scarred down, and somebody may, in cases where people don't have metastatic cancer, it may even be treated with a lung transplant. Now, we don't transplant people who have metastatic cancer, but I just put this up there that this is something that we have a very high index of suspicion. It's not common, but we always need to check for it. Okay.
Hmm.
All right.
So that was a very important point you bring up, and just wanted to backtrack a little bit. So doctors have the concept of like pneumonitis or this or ILD, and the disease entity itself is something that doctors have been treating, and they know how to treat, correct?
Yes, they do know
Yes.
how to treat. And I will say that both of these protocols, the IDA 01 study and the IDA 02 study,
Right.
both of these have guidance for assessing, diagnosing, and treating ILD. And there's
Okay.
actually been educational trainings that have happened with all the investigators. So there's, again, a lot of learnings around treating it, dealing with it. Um, it's not uncommon. And I have to say, even docetaxel causes
All
pneumonitis.
right. That's
It's a
right.
side effect of docetaxel.
That's what it's saying. It's not like
Yeah,
it's not like it's something that clinicians haven't been exposed to and haven't
no,
been successfully treating it. It's like it's
no,
not new. It happens to be a side effect for this particular
correct.
but other drugs or immunotherapies may have a
Yeah,
side effect. Now, let me ask you a question. And you go a little bit, you said something that was very important that the doctors know how to treat it, uh, but does the patient go home with an electronic diary, or how do you empower the patient to make sure
yeah.
they report these symptoms as early as they possibly can?
I think it's education. I don't, I have to say, I'm not 100% if they have a symptom log diary that they're tracking. I don't think that that's happening for O1, certainly, because it's a large registrational
Yeah,
phase
yeah.
study. But there's a lot of education. Everything is in the consent form. Usually, doctors and nurses are talking to patients about it. And it's just being on the lookout. I think it's okay if you're noticing a change in your respiratory status, let the team know. Don't wait until the next visit. Like, as soon as you start to notice something that's off, let the team know. If you have a fever, let the team know. And, you know, it may not be ILD. It may be something else that's causing the
Right, right,
symptom,
right, right,
but
right, right.
let the team know so we can do the appropriate diagnostic workup to identify it and treat it early. That's the big take home message.
Now, you said there was something else that I wanted to kind of repeat again. The informed consent,
Mm-hmm.
or because there's a protocol
Mm-hmm.
for the research study, but there's also that information that you as the investigator or your support staff takes the time to review all of this stuff with the patient. They just don't
Mm-hmm.
just send you off about your way. You basically want the patients to understand, side effects. They want you to understand dosing. They want you to understand as much as they possibly can,
Absolutely.
which is different. And this is why, participating in clinical trials is almost like you have so many eyeballs on you treatment.
Yes.
You can conceivably get the best possible care for your cancer if
Yeah.
you participate in a clinical trial.
That's actually a very good point. That's actually very true. The informed consent document distills the protocol down into layman's terms
Hmm.
to break down what is the purpose, what is the disease, what's going to happen to you, what are the risks, when are you going to get various things done, and it breaks it down into layman's terms. And so that is there and always available. And to comment on outcomes of patients on clinical trials, there's been some work that's done through SWOG and others, independent of the outcome of the clinical trial, independent of whether the trial is positive or negative. There's been some large, what we call meta-analyses that have
All
taken,
right.
patients that have just received care on a trial, independent of the results of that trial, versus people that were receiving care not on a clinical trial. And yes, there are biases that need to be corrected for, but when you
Mhm.
do that analysis, people that get their care on a trial or have received care on a trial do better than not. And I think that speaks a little bit to the point around the level of scrutiny. The
Hmm.
scan, there's like a very clear tempo of imaging, labs, scans, oversight, guidance that happens in the context of a clinical trial that may not, be in place otherwise. So I know we're kind of
Okay.
working through this. Maybe we can go to the next slide. Alrighty here. Thank you,
Good.
Jerry. And so I think one of the biggest questions is like who can join these trials? So every trial has a listing of what we call eligibility criteria to make sure somebody is safe and in the right disease setting to go on a
Mhm.
trial. And so in general, for these trials, you have to have hormone resistant disease or castration resistant disease. Um, there's other eligibility criteria that are in there. Your blood counts have to be at a certain number. You got to not have lung disease. The prior treatments. There's some guardrails around the different kinds of therapies patients may have seen before. And at the end of the day, the reason why that's in place is we're running a controlled experiment, and we want to make sure that we homogenize. We have as many variables and factors um, accounted for. Like we don't
Right, right.
want to have people of all different shapes and ultimately, yes, we want to get to those answers, but like to be able to prove that this one thing that we're doing improves long-term outcomes, we don't want to have a hodgepodge
Right, right,
of
right.
people that go on. You're never going to be able to prove that one thing. Could it be some other variable that impacted something? So we
And that's why
try to have it, yeah.
And that's why I think you said mentioned before that people that had either a past history of that of the pneumonitis, the lung
Mhm.
inflammation, may will probably not be or not a good candidate for this.
Right. Yeah,
Okay.
exactly. Um, let's go to the next slide. And so these are additional inclusion and exclusion criteria. We're not going to go through these one by one, but these are really just put up here to help understand sort of the nuances. When somebody signs consent that they're agreeable to participate, it doesn't guarantee that you're going to be able to enroll. When you sign consent, you enter a screening period where we say, okay, you've heard all the details about the drug, you've heard everything, you're willing to go through this process. Let's make sure you're safe. Let's check your blood counts, let's check various things, get your scans. If you check through all those boxes, then yes, you can be enrolled. So just because you sign consent, doesn't necessarily mean that it's a guarantee that you'll be enrolled. We want to check and make sure that everybody that goes on is safe to actually receive treatment. Okay. Let's go
Hey,
to the next slide. Yeah,
quick
go ahead.
question. So if I have asthma, I could still participate in this clinical trial because it didn't look like it was an exclusion for people with asthma.
Yeah, not directly asthma. I think if there's what we call interstitial lung disease or some other lung problem like, COPD or other, you know, um, scarring or
Yeah.
fibrosis or these sort of
Or
other
even,
things.
the people who had COVID, there are a lot of people who have the problems after COVID with their lungs. So I can see how, um, but at least, if you're, yeah, I guess severe,
Yeah.
yeah, asthma or something like that. Okay.
Yeah. So
Um,
what is unique also about this trial is we said this is our attempt at better personalizing chemotherapy administration, right?
correct.
This is our attempt so we can better personalize treatment. And we said that this IDXD, it targets B7H3. It targets a protein
Hmm.
on the tumor cell.
Right.
Um, and that's the entry point for the drug coming in. So to get on the trial, one of the, criteria are actually to do the analysis of getting the tissue and staining for that protein. Is it there? Because if the protein is not there,
Okay, I got, yes. Then,
how are we going to get the Trojan horse in the door? Like,
right. So you need to at
so
least have that key, the key to get
correct.
inside. Okay.
So, now the reality actually is that B7H3 is very highly expressed on prostate cancer cells. Many, many prostate cancer tumors have high B7H3 expression.
Mm,
So, but these studies are doing the analysis of checking the staining and seeing if there is B7H3 present and whether that impacts
mm,
how somebody's going to do,
mhm.
So as part of this trial, we're doing that precision analysis. We're attempting to better understand the personalization of treatment. Okay.
Okay.
We can go to the next slide. And so we get this question a lot, how long will you be on a trial? What happens during the study visits? So for many trials, you're on as long as the treatment is working for you, as long as it's not too toxic and you're tolerating it okay, you will stay on the treatment. At any point in time, you can decide to come off the treatment for whatever reason, but generally, patients stay on treatment as long as it's tolerable and it's working. Okay. So, and there may be some adjustments to be made. Maybe a treatment needs to be, if somebody having a side effect, we may need to adjust the dose. We need to hold the treatment, whether it be in the chemo arm or in the IDXD arm. And then when you're on the trial, you're getting PSAs checked very regularly. You're getting scans done very regularly, every 6 weeks, getting imaging. And we take a look at the scans and say, okay, there's no new spots. Nothing is significantly growing. We can keep you on. It's working for you. So, and with this trial, if we have a suspicion that something is not working, you know, we send the scans off um, to be reviewed to confirm, yeah, it is or no, it's or yes, it's working, no, it's not working. So there's a lot of eyes that are looking at this. And when you're coming into the clinic, like I said, this treatment's given IV every three
Mhm.
weeks. You're getting blood work done, you're getting urine tests done, you're getting a physical exam assessment, doctor, nurses asking you how are you feeling, and then of course the scans. And that's how we know if the treatment is working and safe. Okay. Let's go to the next slide. So we started to talk about the screening period. So I think when
Right.
I like to break down a clinical trial, it's
Right.
the screening period, the treatment period, the follow-up period, and long-term follow-up. So screening is you sign consent, you want to do it, you're enthusiastic about it. Okay, let's check to make sure you're safe to go on the study. Let's get your scans, get that tissue piece collected, get your blood work, make sure everything is okay so that you can go on. So there's
Hmm.
that period. When
Right.
that is done, and say, okay, great, we check the box, you go on treatment. And then it's the treatment period where you're actively getting therapy.
All right.
We check to make sure you're safe. We check your blood work. We check your scans. When the therapy stops for whatever reason, whether it be toxicity or it just isn't working anymore, whatever reason, then you enter into follow up.
Okay.
Because even though you're not still actively receiving treatment, we want to see how you're doing. We want to check that people are still living and doing whatever it
Right.
is that they're doing. And we want to check what other treatments you may have gotten after this treatment, especially in the control arm too. We want to check, maybe the docetaxel chemotherapy didn't work and we want to continue to follow people. This
Hmm.
trial, the ID801 study is tracking survival. We want to prove that this therapy makes people live longer. So we
Hmm.
have to track people for a long time
Hmm.
to see and look and show that actually we are making people live longer. People that got the IDXT are living longer than people that didn't. So even though the therapy may be stopped, we're going to still track the effects of down the
Okay.
road what's going to happen.
Right.
Okay.
Right. So
Oh.
that's nice. That's nice. There's the follow-up.
Hmm.
And I see that you have monthly calls and emails.
Yeah. So
It-
when people are in long-term follow-up, it's not as onerous. We're looking in the medical record every 3 months. We
Mhm.
may be giving you a phone call, make sure, hey, how you doing? Mr.
Right.
Jones, you're still doing okay? Did you start on any new cancer treatments? Okay, we may be looking in your chart, but it's a really low lift. Okay. Next slide. So again, you may or may not be familiar with clinicaltrials.gov. It's
Right.
a website that includes key information about many clinical trials, thousands, hundreds of thousands of clinical trials. And a way that we label clinical trials is with this NCT number, clinical trials number. And
Hmm.
this is the number for prostate, ID8 prostate O1 and ID8 prostate O2. You can access the clinicaltrials.gov. It's publicly available to see the eligibility criteria. You can see where the trial is open at. There's a listing of all of the trial sites. There's also this tool through Merck that you can access with this QR code to help provide more information about these two trials. We can go to the next slide. I
And
think
I think
that's our Q&A session. So I know that was a lot.
that was a lot.
We went through a lot of information about trials and IDXD and the two trials themselves. And IDXD, the O1 study is an international trial. It's open at hundreds of sites. And
Hmm.
so on the clinicaltrials.gov and accessing the QR code, you can see if there's a site next to you or at your
Right.
own site that, you could ask your doctor about this.
And let me ask you, you know, we like to, first thing, again, I'd like to thank you. Excellent job as always. Um, and then we'll do our poll questions, and matter of fact, Jerry, you could put up the poll questions now. If you had like a minute or 2 minutes, And what would you say to caregiver and a prostate cancer patient that's sitting in your office about this trial? And I know I may be putting you on the spot because there's so much stuff that we covered.
Mhm.
Everything we covered was excellent. I mean, so if you have a 2 minute spiel, elevator pitch for this trial, what would it be?
You know, the what I would say is castration resistant prostate cancer is a tough disease to treat.
Hmm.
There's only a limited number of drugs that I have on the shelf that I can prescribe to any individual to help improve their survival. The two goals of therapy are to make you live longer and make you feel better. And the standard of care, there's an insufficient number of treatments. If I can expand the number of drugs I have in my toolkit, and if we have a match of a trial for which there are spots and a patient that is eligible, I always try to match it up because I can prescribe docetaxel anytime. I can
Right,
prescribe an oral RP anytime. But the match doesn't always happen. And when it is afforded to us, I jump on it. And I
right,
tell patients, you're in control. You're going to be watched like a hawk. At any point in time, we can decide to, do something else. And if some people have well, I'm going to be randomized. I'm not going to know, or I'm not going to get to pick. And I say, if you decide to not do the trial, your likelihood of getting IDXD is zero. It's
right,
0%. Okay.
right. No, no, that's true.
If you decide to do the trial, your likelihood of getting IDXD is 50%. And for the O2 study, it's even higher because there's multiple cohorts of IDXD.
Right.
So I always use that to like level set. And I think there's a lot of enthusiasm around ADCs. In breast cancer, they are the standard of care. In bladder cancer, they've revolutionized the treatment of bladder cancer. I mean, when the data for the bladder cancer ADC were presented for frontline bladder, there was
This is back in February, or
it was actually a couple of years ago at ESMO at the European
oh,
Society of Medical. I mean, it was a standing ovation that lasted over a minute when the data got presented about the ADC that has revolutionized the treatment of bladder cancer.
so that's
There,
interesting to say
yeah,
that. So what you're saying here is this, is that the prostate cancer folks are
we're behind.
okay. I was saying late to the game, but yeah, we're behind. Everybody
We
else is
don't have an ADC, and
we
this
don't
is this is the farthest along ADC that's in a registrational strategy in the frontline MCRPC setting. And I have to say, there's not been a drug that has beaten chemotherapy. Docetaxel chemotherapy has been tried and true for a long time, and there has not been a drug that has beaten chemotherapy. And we are going big and hard because I think that this can be groundbreaking for the field, honestly. And the same was true when the ADC and bladder, I'm going to bring us back to bladder, you
right,
know,
right,
cisplatinum, carboplatinum chemotherapy was like nobody even fathomed that a treatment can outperform cisplatinum and carboplatinum chemotherapy. It was like, not like, it was like, how are you going to, you know, challenge the king?
right,
You know
right.
what I mean?
Okay,
Or
okay, okay.
the queen, however you want to say
Yeah,
it.
yeah.
And that's why when the data were positive in bladder, I kid you not, I was getting chills in the room,
Right,
you
right,
know, because it was so exciting for patients. That's really why. It was like, "Oh my God, we've done it." Like we've beaten and improved outcomes over just like generalized chemotherapy. So I think this is going to be very exciting. I'm super pumped about it. And
Are we
the
well on our
hope,
way?
yeah.
Are we well on our way to I know obviously getting hopes up, and I don't want to get too ahead of my skis. The prostate cancer being treated like it's a chronic disease?
I think that we are on our way, and I think novel therapies, um, IDXD being one of them, and others are going to help us get there even faster. And something that's very near and dear to my heart, that's not necessarily part of this exact conversation, and I think we touched on it, last time we connected, but how do we actually cure more men of prostate cancer? And how do we prevent people from developing metastases in the first place? How do we identify, individuals that maybe that they don't have lethal disease as of yet, but they may be destined to develop it? How do I find who those people are and intercede with a therapy that's going to prevent them from ever developing lethal prostate cancer? Because I think if we do that, it will be a win for the field. Yes, we need to treat late stage. And yes, we need to treat individuals who have refractory disease and metastatic disease. And we need better drugs that are associated with better durability and better survival. But how do we prevent it in the first place?
Okay. Okay.
Yeah.
And I wanted to before we go to the the survey, just that there's some folks in the audience that said that there were nine topo I B787. So it's but the clinical trials that were using the topo I. But I think that if we refer back to the NCT numbers that we showed, so with the NCT numbers, you should be able to find the
Yeah.
clinical the specific clinical.
Correct. Those NCT numbers are specific for the trials we talked about. ID8 prostate O1 and ID8 prostate O2. There's other, B7H3 ADCs. I think this is the farthest one along. And I think, you know, like, it's that super excited. I think it's going to be an exciting time. So I think,
All right.
you can certainly look this up on, clinicaltrials.gov, as I've stated. Utilizing those NCT numbers is really the way to go.
Okay. So we're going to
Yeah.
get you out of here. Is Jerry, are we finished with our survey? And can we put up our what we've learned? Okay. Now, the first one after the session, how clear is your understanding of metastatic castration-resistant prostate cancer, MCRCP? Very clear, 67%, somewhat clear, 33%. So that's good. And so it's a complicated subject, and I'm glad we started introducing the changes in terminology now earlier on, so we can start incorporating that. After this session, how well do you understand clinical trials as an option in prostate cancer care? 67% said very well, and 33% said somewhat. So again, we're moving in the right direction, and we'll just keep on doing these sessions. After this session, how well do you understand the difference between uh, ID8 prostate O1 versus ID8 prostate O2? Very well, 60%, somewhat 27%, and 13% not well. But again, we have time. This episode is recorded, and we'll direct you to the patient summary. And also you can call us at Finn and we can help better explain the clinical trial. Next, how confident are you that you can ask your care team informed questions about clinical trials, eligibility, safety, possible next steps? Very confident, 46%. Somewhat confident, 46%. Not confident, 8%. 8%. That's very good because a lot of folks would be not very confident at all to bring up clinical trials to their doctor. How prepared do you feel to weigh potential benefits, risks, side effects, and time commitment if considering a clinical trial? Now, very prepared, 38%, somewhat prepared, 54%. And again, we're looking at some pretty good numbers here. Next, which next action are you most likely to take after the session about clinical trials and MCRCP? Ask your care team, 25%. Look for more information and resources, 33%. Review FinPath and the clinicaltrials.gov or similar resources, 42%. So this two, the first one, all of these are important because one, we're moving, it's a lot more people, even though you may see 25% is kind of low, but it's not really because you're moving more and more people and the numbers were lower than that, like in the teens. So we're moving in the right direction. We also getting people to recognize 42% people who are interested in reviewing these clinical trial sites because they may find something for another clinical trial. Seven, um, how familiar are you now with finpath.com? Very familiar, somewhat familiar. So that's good because that's our internal resource that we kind of simplified it so it's easier for people to find clinical trials. Which statement best reflects what you learned today about clinical trials for MCRCP? Clinical trials always lead to one standard treatment path? No. Patients should wait to ask questions until after a treatment plan is screened. Clinical trials may have different study goals, treatment goal groups, study considerations, eligibility requirements. Patients should ask questions before 83%. That's what we wanted to make sure people have a good understanding. Nine, did the learning session help you better understand clinical trials? Yes. 73, 77%. That is good. And then somewhat 23%, but no one said no. So we're leaving people leaving here with a better understanding. And 10, will you now consider participating in a clinical trial? 67% said yes. 33 said no. 67% is a good number. Are you a potential candidate for a clinical trial for the clinical trial presented in the learning session? 8% said yes. 67% said no, and 25% said not sure. 8% is still a good number. That means that somebody's interested that fall. And it's like we've recognized that not a lot of our folks are metastatic castration resistant, but at least they have a better understanding of the clinical trials and they feel that they may be a good candidate. How do you rate the learning session presentation? Excellent, 64%. Good, 36%. Excellent and good, I'll take those numbers. Dr. McKay, all right. And how do you feel about the session pace? Just right, 80%. So that, I told you rock star on board. And 10% said too fast, 10% too slow. But that's all right. We'll get it's a complicated topic but we want to make sure that a lot of people understood. And then who was here? 60% said prostate cancer survivors, spouses 10%, advocates 10%, medical professionals 10%, and then others 1%. Well, again, Dr. McKay, thank you for taking time in the afternoon.
Of course. Thank you so much.
And then, because we're trying to get those folks out there to Southern California. It a beautiful city.
It's a beautiful city. You've just done such a wonderful job explaining everything and really moderating and driving the discussion. I'm always so impressed. So
No,
thank
I
you
mean,
all, and I'm always happy to answer any questions as they come up.
I said I'm just saying that you explain it, and then your ability to explain really, it's almost like people feel like they're in your office, and that's how comfortable that you make people feel
Thank
you're
you.
talking about clinical trials. So thank you again.
Thank you.
I see you.
Bye, everyone.